Good evening, everyone. Welcome. I'm Diana Ingram. I'm the executive director here at Hill Center at the Old Naval Hospital. And I'm always curious, is there anyone who's never been to Hill Center before? Hooray! Welcome! Come back! Check out our website. Look at all the fabulous other things that are happening. Welcome to At Issue. It's a new public affairs strand that we launched a couple of months ago. A moment on Capitol Hill to look at issues facing the United States. Tonight, we're examining the challenges facing public health institutions, and we certainly have a dynamic group. This is the very first naval hospital. It was commissioned by Abraham Lincoln during the Civil War, and then served as a wonderful public health resource for contractors and workers at the Navy Yard, and also members of the Navy and Marine Corps. 159 years ago in October, it opened its doors and admitted its very first patient, Benjamin Drummond, who was a black seaman, and he suffered from chronic injuries sustained during the Civil War. So it's a very appropriate place to have this conversation tonight. Please take a moment to turn off your mobile devices. And it is indeed an honor to welcome John Brooks, the former Chief Medical Officer at the Center for Disease Control and Prevention's Division of HIV Prevention, and Dr. Anne Schuchat, who was the Principal Deputy Director at the CDC and served twice as Acting Director. The discussion will be in excellent hands with moderator and award-winning journalist Nicholas Florko, who writes about health issues for The Atlantic. I guess we don't call it The Atlantic Monthly anymore. The Atlantic. A notorious magazine at the moment. He covers the impact business and policy have on our well-being with a focus on products that make us sick. So the format tonight will be a conversation, a moderated conversation, and then we will open up for Q&A. We are recording this, so I please ask you to wait for Marianne Brownlow, our executive producer of this series, who has done a phenomenal job setting this up. Just wait for her to bring the microphone so that everybody can hear your question. So, Nicholas, thank you for being here, and I'll turn it over to you.
Thank you so much. Thank you, everybody, for being here. I think everybody knows we're in the audience today talking about the dismantling of public health, and I probably don't have to tell the group that there's plenty of dismantling going on. For those that aren't aware, thousands of folks at CDC laid off, full divisions closed, and so we're going to get into the impacts of all of that. But before that, I wanted to just comment that I don't think there could have been a better day to have this event, because not only did we have an ACIP meeting this morning talking about vaccines, we also had the confirmation hearing for the new CDC director. So plenty of breaking news to also chat about today. But I was hoping we could just start with some stage setting, and I'm hoping you both could give us your thoughts on just the state of public health at this moment.
Sure. Thanks so much, Nick, and it's great to be here. I see there's a lot of expertise in our audience, so it's nice to see you all. Public health is used to dealing with really bad things, and the workforce is very resilient, but the current situation is grim. So I would say that the workforce, whether it's at CDC or state and local public health, or certainly the global public health workforce, is demoralized, dejected, frustrated, probably in shock. And there are real harms that are happening. So, there's a lot of potential for solidarity and innovation, but it's just such an assault on every dimension right now.
Yeah, I would echo that as well. I think and just I want to thank you all for coming as well. It's great to see this turnout today, especially given the weather. It's pretty hot, as you can see, as you know. The other thing that's very different is that normally the assaults on public health come from outside. From disasters or from medical problems or from injury problems that really can be overwhelming. Both of us have been through numerous national emergencies and had to really rally forces, and it's extraordinarily challenging to respond to that. I think this might be one of the first times in U.S. history where the forces that are challenging public health are coming from within the government itself. And it's part of that is the reason I think so many people committed to public service that work in these jobs are demoralized, because the purpose for why you're there is being challenged by the institution that has brought you in.
Can we get a little bit more specific? I'm curious, we're talking about dismantling. When we're talking about that, what are we really talking about, and what are the sorts of things that keep you all up at night thinking about?
Well, I could talk about the dismantling of public health. Maybe you could think about the things that keep you up at night, because I'd like to hear if your nightmares are my nightmares. But this coming here was a great opportunity for me to think about, what does dismantling public health mean? And I kind of thought through it a bit and thought, there are kind of 5 easy steps for dismantling public health. First, you make public health blind by removing their ability to detect what's going on. Public health is built on keeping track of illness and injury and knowing, is it going up or is it going down, and reacting to that. The second is to make it powerless by removing the resources that you need to execute preventive services. So you get rid of all the people who do those services, so they're unavailable. You tie up the funding. You either cut it off or slow walk it, so that the resources aren't there anymore to execute the mission. You then make it irrelevant. And what I mean by that is you move people's focus from prevention to treatment. Because really, if you get cancer, what do you care more about? That you didn't get it, or when you have it, that there's a cure? And you're seeing this hyper focus on treatment. And if we come to HIV, I'd be happy to give a good example, but there are examples of this in many areas, of moving measles away from the vaccine and reminding people, well, it's not a bad disease, and when you get it, we might have things to treat it. Then you make it unnecessary. You impugn the credibility of the scientific experts who provide the advice that underpins public health, and that underpins the groups that provide advice to the federal government. These expert committees, you either impugn their credibility based on conflicts of interest, or you introduce doubt into the science that they rely upon. And then you see these advisory committees like ACIP, but many others, if you know HICPAC or CHAC, are all being cut off. And then lastly, you make the need for prevention seem unneeded because you're offering good reasons for what you're doing. You seem to justify that, well, I'm really working in your best interest to save you money and to build economies of scale. So that's all happening right now.
Yeah, I think in terms of what keeps me up at night, I always used to answer that with the idea of pandemic influenza, and of course now we just broaden it to pandemic anything. But the reality is the pathogens are still out there, and they're still mutating, and we have very little visibility, and the front line is weak or not there. But the other thing that I think is much worse than during these many emergencies that we were part of is the information environment, because there is truth, but it's really hard to find. And the trust and credibility help people believe truth when they see it, but there's a really organized effort to dismantle trust and credibility. And then, we got a lot of media training at CDC, and we had the sort of mantra of, you want to be first, but you want to be right, but you want to be credible. Mm-hmm. And it's really hard to do all of those things at the same time, to get out there before the disinformation happens, and to include, avoid absolutes, and include openness and honesty, and dilemma sharing and so forth. The problem right now with the information environment is there's no first. Everything's at the same time, and we're all listening or watching to different channels. And so we're in a lot of different realities now, which makes the job of public health much, much harder.
Since we're talking about the information environment, I want to just ask a bit about CDC messaging writ large, because I feel like that was one of the things that was taken away from the COVID pandemic. There was criticisms, frankly, on both sides at points about CDC's messaging and sort of whether it was clear, whether it was quick enough. And I'm just curious, with hindsight now, what do you think of those criticisms? Like, were those valid? And if so, what was the root cause of them?
Yeah, I think that there's a lot of validity to that. I don't think there's a person in America who was not confused during COVID. And maybe some of us were confused in January 2020 and other people were confused in January 2021. But, pandemics are confusing. And in an information system that is, 1960s, you can have Walter Cronkite kind of giving you the play-by-play. And today that's not possible. I was surprised during the pandemic about the criticisms that CDC was too academic. When I got to CDC in 1988, we were like the quick and dirty people. We just got right out there, and the academics were upset that we were doing these, rapid studies to get enough information to take action. But I do understand that the information was complex and it wasn't always accessible in the ways that people needed it. There were other factors, though, during some points where the information was controlled and CDC wasn't the voice. And so I will take all the criticism until we were not allowed to talk. But once we were not allowed to talk, I would blame other factors.
Yeah, I just want to highlight the ability to talk, because I think that's what buys public trust, is that as an agency, all of us were trained that, you speak to the public on a regular basis. You're always available to answer questions when they come in. You're a trustworthy companion for them in this journey through figuring out what's going on. And you're going to say, here's what I know, here's what I don't know. Be expected that things may change, and I'm going to let you know when they change and explain it to you. And our ability to do that was completely cut off. I mean, I remember when I was in other areas of CDC and foodborne or other outbreaks, we would have regular, almost daily, press conferences with the people on the front line doing the work. And instead, that really got cut off.
Yeah, and it wasn't just us, because in most of the earlier emergencies, we would have very regular dialogue with the state and local public health or with World Health Organization or other countries. And we would be sharing information and foreshadowing, like, today this is going to happen, or hearing from them, today this is going to happen. But that was, I wouldn't exactly call it controlled, because it was chaotic, but it wasn't, we weren't in the driver's seat for that.
And when we tried to do that, it had to be very careful that you was trusted partners who you could share something with and sort of field it, or socialize it is a word people use a lot, to see where it might land and make sure that you're going to go where you want it to go.
But I think to be self-critical is important. And COVID, like many of the previous emergencies, but on steroids, had such a different context in different places. So, it was morgues in the street in New York City, and nothing was happening in Oklahoma. And at the national voice, you had to really gauge how you talk about this so people know, your local authorities are the people you need to listen to. We had very weak data systems and lab systems to have that situational awareness of what was happening everywhere. And so the first several months were very confusing because of that.
And I worry now that those lessons learned in the next pandemic may not actually be able to be applied, at least in the current environment.
Sure. No, I mean, as someone who communicates for a living, I do not envy the job that you all had trying to communicate, especially in the early days of COVID. And on the COVID front, I have COVID at the top of my mind because of the conversation today at ACIP. As if folks that don't know in the audience, the first meeting of the CDC's advisory panel after Secretary Kennedy fired every member of the existing panel for purported conflicts of interest, and then installed a new slate of folks, numerous of which are known vaccine skeptics. So it's very interesting to see sort of how that conversation played out today, especially over COVID. But I know that you all likely watched as well. I'm curious what stood out to you all.
Yeah, I mean, I watched a lot of it. I didn't watch every minute, I have to confess. I got kind of tired. But I think there was one really good feature for anybody who did watch ACIP, the Advisory Committee on Immunization Practices. The presentations were painstakingly thorough and evidence-based, and I thought fairly clear. One problem was that the members were so newly appointed that they hadn't got the usual weeks or months of run-up to the meeting. So they may have been overwhelmed by all the data. But I think for claims that the vaccine policy that CDC recommendations rely on, is not evidence-based. It was really clear it's evidence-based. And I think that was a good thing for the public and the media to see. It just is unfortunate that, what I think was a very good process got completely derailed, short notice to appoint a small number of members without the range of expertise that the previous members had.
I will say, too, the thing that really stuck out to me was there were very detailed presentations on sort of the safety and efficacy of these vaccines. But the thing that I noticed that really stuck out to me was this sentiment among folks, panelists, who would say, we see your data, but we want different data. And we're not going to trust your data until we get that data. And I feel like that's going to be one of those things that we see playing out over the next few years, because we saw at the start of the committee as well this announcement that they're going to start a new work group to relook at the data around the childhood vaccine schedule. So I don't know how we get around that, I guess. How do you fight this point of we need different data when there's already so much data already available?
Yeah, it was really like a time warp, because the claims and concerns that were being raised were ones that were raised in the early 2000s. There were a series of hearings. There was a lot of studies that were done. Institute of Medicine, now the National Academy of Medicine. There's just been an enormous amount of research, and particularly for autism, for thimerosal, for MMR. There's just been an enormous amount that has been learned. The issue of the schedule has been looked at carefully as well. And so I think we're going to be spending taxpayer money to do it again. And whether the way it's done and the way it's presented is going to be credible, I think is a real question, especially based on some of the questions we heard today.
And it's going to be a real demand on the public and the press and other experts to look carefully at alternative data that's introduced or presented.
I want to turn to another topic that I find fascinating this moment, which is HIV/AIDS. Obviously, this was a priority of the Trump administration in the first term, and it seems like we made some real big strides there. So, John, I was hoping you could help us understand what had happened during the first Trump administration, where were we, and now what has happened since, and where does that put us?
Okay. So, starting in around 2018, the new director of CDC at the time, Robert Redfield, who has his entire career was built on HIV treatment and prevention, came in and with some other experts, including Anthony Fauci and some other people at HRSA, recognized that at that time we had the tools to eliminate the HIV epidemic in America. We had extraordinarily effective treatment that prevents you not only from dying early, you go on to live a healthy life, but it also stops sexual transmission. So it has a treatment and a prevention benefit. In addition, for people without HIV, there were these new drugs that are extremely effective, well over 95%, at preventing a person from acquiring HIV if you take it. So they said, listen, we can get rid of HIV in America, get the epidemic to down below 1 per 100,000 infections per population. That's the definition of elimination. And we were at about 30,000 at the time, so we got to get below that. And we wrote a compelling story, presented it to the White House. The president liked it. It became a signature program for his administration, as PEPFAR was for the Bush administration. And he announced it in 2019 at his State of the Union address. Thank you. State of the Union address. This was instrumental in galvanizing the prevention and treatment community behind a foreseeable goal. We made an ambitious plan. We will get it down below 3,000 infections nationally within 10 years, which I believe and still believe was entirely achievable. There have been some bumps in the road like COVID-19, but it's doable. And things are looking better, just by the way, in the advent of all these new technologies for treatment and prevention. Well, things were going along really well. The most recent look at the sort of the state of HIV in America is terrific. In the period between 2018 and 2022, after the EHE, Ending the HIV Epidemic initiative, was put into place, there's been an unprecedented 12% decline in new infections. Now, that may not sound like a lot, but you need to know that in the decades before that, it had just been cruising along at pretty much the same 45 to 50,000. And by 2018, it got down to 31,200, and the trajectory looked great. Not only that, That decline was in part due to a 30% decline in young people aged 13 to 24, a very high-risk population we cared about. Further, the number of deaths declined, 19%. So that's a huge decline in death from HIV. So that's remarkable. And during the same period, we achieved perinatal elimination. That means we achieved that less than 1 in 100,000 number in terms of number of women with HIV transmitting to children at birth. So things are going in the right direction, and this initiative has worked. So it strikes me as hard to understand how things changed.
But I think it's disappointing and very discouraging, but it isn't new for administrations or Congress or authorities to feel like when things are looking better, we can pull the money, because that is what happens.
Right.
You know, when things were looking better for measles in the 80s, they pulled the money, and we had a humongous measles epidemic. We saw it with TB. We've seen it with many, many conditions. So it's not like we want to have to pay for things forever, but the idea that an investment in sustainable interventions isn't necessary. You know, I think this feast and famine is a thing we hear about, but I do think that it's just really sad because the increase is going to be on their watch.
So this is what is the really bad part of the story, is that we have every reason to believe infections are going to go up. The current administration is focused on treatment for HIV, these miracle drugs that make you live or allow you to live a normal lifespan and prevent you from transmitting. But only 61 to 65% of Americans are in that very hallowed place where they're getting effective therapy, so they are suppressed sufficiently to not transmit to others. That's a pretty large fraction. 35% of people with HIV aren't getting that. Furthermore, this prevention intervention, using drugs for preventing HIV, PrEP, is off the table right now, despite the fact that 2 weeks ago, or maybe it was last week, FDA just approved a new drug for this purpose, which is an injection you need to receive once every 6 months, and it can be administered subcutaneously, which means that any doctor can administer it like a vaccine, and you could even do it at home. And there's more coming down the pike like that. So it's unfortunate. And I'll just add one last thing. HIV costs a lot of money. The lifetime cost for each new infection is about $500,000 conservatively, maybe $1 million less conservatively. If we continue where we are now, even if there's no increase of about 30,000 infections a year, that's $15 billion to $30 billion of lifetime treatment cost that go onto the backs of every generation. Each year, another $15 to $30 billion. So it's also very cost effective to spend the money now to prevent this from happening. And this is so true for every other public health intervention.
Can I just ask, you both are out of government service now, but for the folks that you know that are still there, what is the climate like right now, especially for someone working in HIV, right? You are finally seeing this huge progress. You're seeing an administration throw support behind you. The same administration comes in and then says, we don't support this anymore. All of you get in the unemployment line. What does that do to the workforce?
Yeah, I mean, I think that I have been spending some time with CDC colleagues and with the state and local organizations, and it's really just, it's very demoralizing. I do think that people are tough and resilient and are in this work not for the glory or the money, but because they really care about it. And so while there's the personal pain, I think the feeling of all this work that we're doing to try to improve the lives of people is going to be reversed. I think the other thing, in some ways it's totally different, but in some ways it's similar, that people are used to working super hard and carefully in really difficult circumstances against natural threats. But it's sort of a little bit like the anthrax response that we both were part of, and I know some of you guys were too, where it was man-made. I mean, it was really upsetting to have so much confusion and, you know, a handful of people tragically die for a man-made threat. And this is so preventable. This isn't like, you know, you didn't get the vaccine. This is human-made chaos and disruption. And I think that is really hard on people. But they also, you know, this isn't true to a person, but I think that there's a sense among some that there are individuals who want the public health workforce to be traumatized, and there's a sense that I'm not going to let them traumatize me. I care about my work. I'm going to keep doing it. Those who are still there, and make the best of it, because we are. I mean, I was, and many still are, really fortunate to work in something that's so meaningful. Where you actually can see the impact that you have. I mean, it's extraordinary. I get teary thinking of the impact that our work has on generations. So I think they're hurting, but they don't want to be hurt because they want to keep going.
I am wondering this is a question I'm always mulling. Why is public health always a punching bag? Like, why is it always the discipline that gets thrown under the bus? Why do people want to traumatize the public health workforce?
Well, I do think that others besides the public health workforce are feeling trauma
Sure,
right
sure.
now. So it's especially in Washington, you have to say it's an equal opportunity trauma right
Sure.
now.
Yeah, exactly.
But one thing is, it's small dollars. It's not a money maker. You don't make, we save money, but we don't make money really in public health. It's not glitzy and glorious. The outbreaks get a lot of attention, but it's the day-to-day work that's really, it's like plumbers is what we are. We're keeping things going in a positive way. And we haven't been that great at the stories. We haven't been, we've had a couple movies, which are good, but they're usually the disaster movies, not the I want to be them movies. So I think we haven't, and then the other thing people always say is that the people who go into public health are fairly humble, and it's not about us, and we're not out there getting attention. And I think there's some disciplines where it's all about, the individual or the attention.
Yeah. And I also think public health is particularly vulnerable to attack because if it works right, it's invisible. Like you said, using this example of the plumbers, and most people don't, if public health works well, it's seamless. You don't realize that your water's naturally clean, that, oh, the food is safe, oh, my car has been designed so I don't die in a tragic accident, or I've gotten swimming lessons to prevent drowning. This is all just part of natural life. So the value of the work that you do makes it vulnerable. People go, well, what do you really do in public health,
Well, in 1955, when there was a national polio campaign, everybody loved public health.
Exactly.
But when we did the right thing and integrated immunization into the primary care system, and doctors' offices were given the vaccines, not the big NAS clinics, we became invisible. And that was the right thing for health system strengthening. It's the right thing overseas. It's the right thing here. But we really became invisible when those big campaigns were not how we did things. The big campaigns are kind of expensive, and they're not, making it easy to get prevention done is efficient and smart and inexpensive, but it sets us up for being overlooked and perhaps being a punching bag.
See, it's so interesting you say that, though, because I would have, perhaps I haven't been in the field long enough, or I was a bit naive, but I would have thought that the campaigns that we just went through, getting us out of a once-in-a-lifetime pandemic, would have done the same thing, would have made people celebrate public health. And it seems like we've still had a backlash.
Well, we had a very organized backlash.
Yeah.
So I would say, I would just say that.
But I would also think about the 1918 influenza pandemic. When it was over, what did people remember? How many people died? They didn't remember how many people did not die. And I think that's the part of the calculus that's hard to display because it's,
But I don't think people are remembering how many people died from COVID. I mean,
Right.
we have a COVID wasn't
That's a good
real
point.
campaign. So this is just unbelievable to me
Yeah.
that, 2 different administrations were in charge during COVID. And we have such a lack of memory of that. I think, reading about 1918, there was a period where people just, put it behind you, move on, don't talk about those families and relatives that you lost. But we had this marriage of the pandemic with the political in a way that that happens every time there's a pandemic, but it was really intense this time. So I do think that those who have a lot of credit that they could claim try to distance themselves from some of those interventions.
And Anne, as I think you pointed out before, in a new media environment, where it's hard to really get the facts that are most reliable.
I want to bring us back up to the present and just ask about the different connections that the CDC has, because it strikes me that the work CDC does trickles down to the states and locals, but then it's also felt internationally as well. And I'm just wondering if you all have any visibility into how what's happening at CDC in Atlanta is reverberating out throughout this country and throughout the world.
Yeah, about 80% of CDC's domestic budget goes to state and local public health, and states vary on how dependent they are on the federal resources, but some states it's 75% or so of their budget is federal government, of health and other sources, and so it's devastating. And then on top of that, you have the NIH and the research funds being pulled that goes to universities that also helps states and locals. But overseas, CDC and the U.S. government have a big role, and we used to have individuals assigned to the World Health Organization, individuals in programs in 60 countries. Yeah. And a lot of that work has stopped. A lot of those people have been brought back. And so we are not in the family of the WHO anymore. And that's a real loss to us, and it's a real loss to them.
Yeah. And you hear a lot about how USAID was sort of soft diplomacy or soft politics. I think CDC operated the same way, as presenting trustworthy, credible experts who could, provide information that was helpful.
Yeah, and I think the other thing that happened today, besides the CDC nominee hearing and the ACIP, was the Gavi, the Vaccine Alliance, had their every 5-year pledging event. And unfortunately, the U.S. announced that they won't be pledging. And unfortunately, the Secretary of HHS, who is not the one who usually provides the resources, did a very inflammatory video for the summit.
What impact will that have? Because I've been thinking about the announcement today. Do you have a sense of what impact that will have just on global public health, the U.S. not contributing there?
Yeah, well, for Gavi, Gavi's a really innovative public-private partnership, and the U.S. wasn't the largest donor. It was 16% of the donations came from the U.S. government, but that's still a big piece. Yeah. And the other countries and other donors are also having fiscal problems, and so it's going to be tough. And Gavi saves lives like in the millions. There 1 billion children individually have been vaccinated through Gavi, and it's really it is life-saving.
And then today, of course, was also the nomination hearing for the new CDC director. I tried to watch that as well with ACIP. It was really interesting just to see the back and forth, her saying both vaccines definitely save lives and vaccines are not connected to autism, but also having to not insult her now will be bossed by second-guessing his policy decisions. But that's actually not what I want to talk about. I want to talk a little bit just about what impact there has been of there not being a CDC director since January. Because I think people forget that essentially no one is in the driver's seat. And I'm just left wondering what that does to an agency.
Yeah, this is another one of those man-made problems. You could argue that it's reasonable that Congress decided to make the CDC director require Senate confirmation. That's a new thing. That it's the first time that's happened for 2025. But not appointing an acting director in the interim is just irresponsible. I had to be acting director a couple times, and things happened when I was acting director. Stuff
They're happening
happens.
right now.
I mean, yeah, like they really did happen, and so I was busy, and my team was busy, and the agency was busy. But at least they knew somebody was talking to the department, and somebody was talking to Congress, and whether it's accepting the ACIP recommendations and taking action. We had the incredible, you couldn't even make this up, that we had the secretary at a hearing say, you shouldn't take medical advice from me, and, a few days later says, here's my medical advice about the COVID vaccine for pregnant women. You couldn't make up that happened, but it just happened. Yeah. So I do feel like whatever, that it'll be really good to get a confirmed CDC director. The agency needs to know who's in charge and not have a shadow director.
Yeah, whenever there's an acting director, unless there's somebody as talented and trustworthy as Anne, you know, when there's not somebody in that seat, the line staff don't know so which way the winds are blowing or what to do. It can lead to a lot of sort of people running around a bit trying to do things, but not really executing with that sense of, okay, I know what I need to do now. But these problems come up. I mean, the lead poisoning one was classic.
Yeah.
You know?
But I think it's also, it doesn't, you know that acting director or the director is not going to win all the battles.
Right.
But they're going to at least voice the agency's perspectives. They're, you know, so with all of the layoffs and with the budget, and you know, the CDC director doesn't really have that much power even when they're permanent, but somebody is a voice filtering the intelligence that they're getting and the perspectives that they're getting to the department. And so I think, you know, being disenfranchised is just an understatement of what the agency feels.
When we first started, I asked about like the current state of public health, and I'm hoping to with the last few minutes talk about like the future looking. So, I mean, first, I want to ask maybe a little bit of an inflammatory question. Is there a future in public health at this point?
I tell everybody I speak to who's thinking about going into public health that you have a very bright future, because there's going to be a lot of problems that need you to answer them. And and it may not be the traditional way that you thought. You may not want to go into a government job, or that government job may never be there again. But there will be communities that need your help. And that may be a community of people, a community of faith, a community of businesses, a hospital system that needs you to advise them, what should I be doing? Because they're not getting the information potentially from a standard centralized source. So that's going to be a job that'll be there. And in my specialty, in yours, infectious diseases, there's going to be a lot more opportunity, I'm afraid, sadly. And the downside to this is that this could pose a really dangerous pressure to our rather fractured and fragile healthcare system. The last thing we need for some of the diseases we worry about is to see a spike that pushes a busy and troubled healthcare system to the point where they can't manage any longer. Maybe not in big cities and states that are well funded, but consider rural areas or under-resourced areas where the hospital there is just managing to get by but hanging on, dependent on a referral source. It's going to be a real problem, I fear.
Yeah, I mean, I actually do think that the future is bright. After the future is really dark, it's going to get bright. But I think, and I had to do a public health school commencement a couple weeks ago, and really, that was tough.
I do not envy you on that one.
But I think that between technology, whether it's laboratory or communication or, you know, everything really, or the importance of the local voice. I think one thing that COVID showed overwhelmingly to me was how important local public health was. That was the voice you trusted. You know, that was the people that knew you, were from your community. And I think whether it's official government or all the non-governmental organizations, those local trusted messengers, community health workers, innovative thought leaders are really going to be the future. So I don't know that public health is going to look the way it looked for my generation,
Right.
but I actually think because there will be a lot of problems and because there are going to be solutions we haven't even dreamed of, that it's a fantastic field. I used to say you have job security because of all the problems, but you probably don't have job security right now. But I do think there are going to be new ways of doing things.
Yeah.
Just as, you know, with Gavi, 25 years ago, we didn't have a public-private partnership that was lowering the cost of vaccines and strengthening the systems to deliver them and getting country ownership to pay for, you know, a portion of them. And we've saved a lot of lives with that. So I do think, you know, in 10 years it's going to be bright.
Yeah.
We might have a pretty rocky couple years.
What about the future of CDC itself? What do you envision?
You're trying to make me cry.
I'm sorry.
I know,
I'm sorry.
This is a little depressing.
The other thing we should say, too, is that we haven't brought up the Administration for a Healthy America, AHA, which is supposedly going to take on some CDC programs. But what does CDC look like in 10 years?
Yeah, I mean, I think we should just call it HA, okay, instead of AHA. But the proposed change is a big splitting up the infectious and the non-communicable environmental injury, occupational health. But in the AHA, it's as John was saying, it's really proposed to be treatment focused. It doesn't really have the surveillance, the lab, the prevention that we think of in public health, and that's being generous because it's not like it's really figured out or we haven't heard what it is yet. Huge cuts to the people and the programs that are supposed to move in there. Mm-hmm. I think that CDC will exist and that it started as a communicable disease center and it expanded because it needed to. It is a really big and complicated organization and it was hard to be acting director over the entire enterprise. But I think, we're going to have many more reorganizations to come, I think, and whether the proposed one is the final one, I wouldn't bet on it.
Yeah, and it's an opportunity for CDC to take advantage of a lot of these new ways of doing things to reinvent itself. But again, we're going to have to get through this darkness, I think, right now. But the opportunity is still going to be there. I also hope it doesn't leave Atlanta. I think it benefits from being just outside.
Interesting.
The
I feel like
Beltway
there's a lot of feelings about this.
I know. Well, USGS is out in Colorado. There's some good agencies that aren't.
The thing that's funny is when you travel around the world for CDC, people don't realize it's part of the U.S. government. Right. So COVID kind of had people realize we were part of we had sort of the best of both. We were government, but we were also viewed as trusted, credible scientific experts.
We have time for audience questions, so we have microphones, so.
Let me give you this one. You're probably going to answer first. Oh, okay. All right.
Hi, I'm Nancy Lee. I was at CDC for 23 years in the Chronic Disease Center the entire time, and I haven't heard anything about that, which is chronic diseases are the leading causes of death in this country. They have been for a long time, and that is why CDC it broadened its mission, which started in the 50s for infectious disease. It broadened its mission in the 70s and late and early 80s, I think, to be chronic disease and then to injury and violence. And all we hear about is ACIP, and we're not funding, the PEPFAR, and we're worried about another pandemic. I am worried about all of those things.
Yeah.
But I am worried because population health is different from the health of individuals, and CDC is about population health. And the other thing is just, you mentioned it earlier, surveillance is at the basis of all public health. And if you don't know what's happening, you can't fix it.
Yeah, I would say, I apologize that we didn't talk about this more. We might not have been talking about it, and the secretary might not be talking about it, but the Congress is talking about it. Yeah. And
well,
the issue.
They wanted to get rid of it.
Well, no, yeah.
Not Congress.
But this is actually it's horrible. Okay, so it's not just eliminating the Chronic Disease Center. A little bit of it will move to AHA. The entire Office of Smoking and Health cut. The FDA equivalent cut. The leading preventable cause of death in America cut. So it's really shocking to have a purported focus on chronic disease prevention and eliminate all of that. So, you may have heard 2,400 people were cut from CDC, pretty much the whole Chambly campus was cut from CDC. They have brought back supposedly about 800 people, maybe half at NIOSH and a small number here and there, but not really the chronic disease group, including the maternal mortality group, just a very important group.
Right.
I just want you to speak about that as well.
I would just add, too, it's fascinating because so much of what what Secretary Kennedy is talking about is the elimination of chronic disease. And that's honestly one of the reasons why I didn't bring it up at first, because it felt like that was the one place where Secretary Kennedy has expressed a lot of potentially positive interest. But as you all have pointed out, the changes to CDC sort of point otherwise.
Well, I mean, I think it's because he's putting that in his independent group, we feel like we've lost that battle. So yes, the voice of how important chronic disease prevention is, we should be, but in terms of the short term, it doesn't look like anybody's trying to keep it at CDC.
Right, and the way that it's been practiced, in the way it's being proposed to be practiced in AHA is really different. I mean, getting rid of food dyes and everybody wearing, health monitors is not going to solve all these chronic problems that we have. The other part about surveillance, Nancy, that you brought up, the other thing I like to remind people is, if you don't keep track of numbers and you don't see them, you don't worry about it. And the problem isn't evident. And that's a very convenient way to stop worrying about firearm injury or lead poisoning or things that get in the way of you executing policies that may be politically motivated rather than publicly motivated on behalf of public health.
Hi. The long-term prospect of public health, I think, is great also, but I'm very worried about that kind of near term, specifically about the budget for FY26, where I read it as basically everything besides epidemic infectious disease control is eliminated. And I'm very worried that in the conversations that are happening in Congress, the fights will all be around Medicaid, and nobody will even think about the fact that CDC's budget is being, of that big portion of CDC being eliminated. So what's your understanding of to the degree to which Congress understands that, and whether they will really push back on the administration and try to restore any of that CDC budget that's being cut in the president's budget?
Yeah, I mean, I did a couple, what do they call, shadow hearings that the Democrats organized both for the House and the Senate, and it was illuminating for them to understand just how much is being destroyed. But over and over, it was what they felt, I think, many of the members, that they have one thing they can really push for, and it's Medicaid. And so I do think that you're right, that it's all lost in the noise. It's part of the strategy. It's just drowning people with hundreds of executive orders and lots of little things, and then, a couple really big things. But I don't think, I'm not very optimistic about that. But I do think that, the public has a voice, and continuing to have that voice. I was surprised that the people from lead and the people from, we talked about lead poisoning and the STD lab and the hepatitis lab, all those things we talked about at the hearings that I was at, and those people are back. Yeah. So make a big noise about, the budget as well. There's, I mean, you just have to try.
And I think the public speaking to decision makers and policymakers with individual stories about this is what it means for me, this is what's going to happen, can illuminate for an independent member sort of how someone in their district or who they're representing could be affected by this. And it crosses party lines. It doesn't matter what your politics are. Everybody suffers from lack of, good services to prevent public health problems.
Yeah, but I think it's all about money right now. Yeah, it's about the debt and about the tax cut. And so we know that preventing chronic diseases saves money, but not the way it's scored. Maybe some people here know how it's scored. So.
And I wanted to ask you, actually, I wanted to piggyback off that question, just to ask, you've been through a bunch of budget cycles. Can you put this one into context for us, just like how, because there's been cuts before, right? But how significant is this compared to what we've seen previously?
Yeah, I mean, there's never been anything like this in this direction. We've had some big increases, but we've never, I mean, it's like about a 50% cut of the budget plus the 25% staff cut. And that's just, CDC, let alone NIH and HRSA, et cetera. The other thing is where we are. It's the end of June, and we don't have release of funds from 2020 from the current fiscal year, and all this rescission. And they fired all the people that were like the contract officers. So when they get permission to actually fund the grants that have been frozen at NIH and CDC, they're not going to be able to move them through the system. Yeah, I mean, right. it's a designed destruction. It's so for the people. I mean, I was the epi physician kind of person, not the contract officer, they fired the people that had all the required training that know how to move the money legally.
Right.
Because they're still trying to do things legally. So,
yeah. And this also means that public health departments in the states and local jurisdictions can't plan. Normally, you'd know by now kind of how much money you're going to get, and you're beginning to see places laying off staff or stopping programs, anticipating that funding is not going to come through, often in a good way that they're trying to give people lead time to find another job. But it's really damaging the public health system that so much of CDC supports.
Let me go over to this side of the room.
It's kind of like
The mic's coming.
Yeah. Hi, my name's Caroline. I am a current CDC employee, and my question
Thank you.
is, how do I get through tomorrow? Because it's only June. There's 3.5 more years. I guess I kind of have a two-part question, because we get emails almost every day about resilience and make sure you have a life outside of your work, and I'm doing all of that. And it seems, I think how do I get through tomorrow, and how do you know what your line in the sand is when it feels like there's not going to be state jobs, there's not going to be university jobs? I mean, I can go back to clinical, but there's a reason I came into public health. So any advice you have?
Yeah, we should talk afterwards. But thank you for what you're doing. And I do really appreciate that it's a day-to-day thing. One thing I would say, which I hope is true for you, but in my 33 years at CDC, the people around me gave me strength and joy and meaning beyond just the work. And so it was so bad sometimes we were laughing about it, but we helped each other. And so, yeah, the outside of work is really good too, but it was those people. And, it's precious to get to work at a place like that where people really care, and there's super good people also. And, but I think the line in the sand is just personal. And, your mental health, your physical health, your family's health, you got to put all of those ahead of the mission, and then you make those decisions. I mean, I've talked to some folks who weren't sure if they wanted to participate in ACIP with all that was going on, and, I said it's a personal decision, but for me, showing the world what ACIP really does, what all those technical reviews are, is a way to contribute. But you can't be a martyr. You got to figure that out yourself.
Hi, I know you guys from way back.
Yeah.
So I worked for HHS for about 30 years, and for about 20 years directed the Title X Family Planning Program,
Oh,
which,
great.
was always on the firing line, as you all know. But my question has to do with, I keep thinking of the analogy of Humpty Dumpty, like how do we put it all back together again, or how does it get put back together again? And are there things that are happening behind the scenes, like either funded by philanthropy or different groups that are trying to prepare for a brighter future so that we are ready when things turn around? And I know ultimately they will, but there's so much destruction going on right now that I just wonder how that happens.
Yeah, I mean, the things I'm aware of are more like the stopgap of how do we survive if, the CDC it doesn't do what it used to do. Things like the Vaccine Integrity Project that's really trying to understand whether some mirror to ACIP is going to be necessary, or, dealing with the insurers, dealing with the states and so forth. But I think I do think there's an opportunity there for individuals in terms of being able to do things in a different way. Theoretically, we want to be more efficient. We want to be innovative. We want to address AI. We want to deal with how the world is changing, whether there were politics or no politics. But I don't know if there's a concerted effort. I don't know, maybe Tom knows if there's somebody out there who's really smart is figuring out how to rebuild city health departments, or how to deal with the domestic challenges.
Yeah. I think also there are a lot of conversations taking place by all kinds of experts and people who care about addressing exactly the question you just raised. Part of the problem also is that Humpty's falling, but we hasn't really hit the pavement yet, if you will, to use the same. We don't know what the pieces will begin to look like, but I'm a persistent optimist in my life, and I do feel that it may be reconfigured egg that we get later, maybe on a sturdier wall and maybe a little swifter, because there is a lot of opportunity. What's happening at state and local level, at least in the areas that I know about, is that they're beginning to think about how are we going to manage things when CDC isn't there to help us. And so there's a lot more opportunity for locals to build on their credibility and have more influence over what's going on.
And there's some regionalization that's going on, groups of states figuring out, okay, maybe we can't have a CDC, but we don't all have to have an expert in everything. We can share some of the burden.
I think what worries people is that those places that are under-resourced and really depend on federal help are going to face the worst challenges.
One of the things I don't think was mentioned tonight is the Secretary Kennedy's attack on science, on professional science. He just mentioned it casually that Lancet was an absolutely corrupt journal.
They rejected my paper, that's it.
And he's considering starting his own journal. So that seems to be...
They did cut the journal lines. CDC had a couple journals that they cut, so I don't know if NIH did as well. But
I mean, he's treating Lancet and other professional journals as if they were the New York Times and other newspapers that attack the Trump administration. I mean, it's...
So one way I can answer that is that the people who edit those journals are really good people, and they are actively getting together to counter this narrative that's being raised. And I don't know if you know I know some of the editors at New England Journal, and they are just really doing a great job of thinking through how we're going to address this and build their credibility. I don't think we necessarily have a lot of influence over that. We depend on them to publish our results and to share it.
yeah, and there was a traumatic beginning to the administration where the government employees weren't allowed to submit their papers. It was before they said disparaging the science. They just said you can't do that. It all has to go through political views first. So it's pretty discouraging within government to be a scientist right now, not just in health and across the board.
I wanted to just quickly follow up on that because I am curious for your all's take, and this is more of probably an NIH issue than a CDC issue, but what would the impact be if Secretary Kennedy's goal of having people publish in the government's own journals be instead of publishing in outside journals? Because I do think there's the MMWR, which is peer-reviewed as a CDC journal. That's not, it's the gold standard, and we're not saying anything bad about that. So I guess I'm wondering, would that be a bad thing if we just start publishing in all our own journals?
It's a big infrastructure to run a journal in one topic, let alone across government. I mean, my God, CDC published thousands and thousands of papers a year. NIH must be, hundreds of thousands. During COVID, of course, unbelievable to keep up with that. So that's making something government that is a good handoff to the private sector. Yes, it's, the MMWR is awesome, but that would, essentially it would be censorship. It would say, we're only going to do the science whose results I agree on, which is not very much. So perhaps it wouldn't be a big infrastructure.
Yeah, or alter your results or present your results in a way that they're in line with what matter to us.
With the answer that I already have.
That's right. Yeah. I mean, even this MMWR, though, is being affected. You may recall it was silenced for a couple of months. Not, by the way, necessarily that somebody, muffled it, but they were losing staff as well. It was very difficult to put together this complex thing you do every week. But the articles they've been putting out are excellent, but very limited, not very controversial. So we'll see.
Hi, I was wondering if you've heard anything about what's going to happen to the fairly qualified health centers.
No, it's part of that the black box of the AHA, and it also kind of relates to what happens to Medicaid. It's just the rural, especially the rural, and actually the urban centers that are serving poor people, right, basically. Or serving people who may be undocumented. There's a lot of impact. Those groups, I do hear in the hearings that I've been seeing that there are members speaking up for that from both parties, but exactly, you know, I think it's fair to say that the dismantling was not evidence-based in terms of, it was like I mean, those of you from government know there are these CAN numbers, there are these admin codes, and they just looked at the admin codes and said, I don't really know what that is.
Yeah.
So the real lives that are affected, you know, for services in hard-to-reach communities and so forth, it's devastating. So I just think it's all about the tax cut and, you know, getting the numbers right for this bill.
And for those who don't know, federally qualified health centers, or more generally like community health centers, are any, like this building perhaps, I don't know. Yeah, but they're a huge provider of preventive health services. And so it's an important component to think about.
We have time for maybe 2 more questions.
Hi, my name's Becky Prevo. I was at CDC for 12 years and NIH for 22. I just retired today, effective today. So thanks. So now I have more time for advocacy, and that leads me to my question. What do you have advice on what the most effective strategy or strategies are? I've tried a couple different things and been, I don't have thankfully, I don't have a terrible story of my own. But yeah, I'm just curious, defending public health, there's what's your advice on advocacy strategies? What's effective?
Yeah, I mean, I think it is weird to be a government employee for decades and then suddenly, you can actually say whatever you want. And I have to think about it. To me, it's actually, I was uniformed for 30 years and in the federal government for 33, and it was important to me to be nonpartisan, to be credible, to be honest, to be, working for the public, regardless of who was in the White House. And so in retirement, I do have to think of, what am I saying and who am I saying it to and how am I saying it, because I don't want to wipe out the credibility that I built up. Right. But I think everybody has, you probably have a way that you think you can be more effective. Is it speaking? Is it supporting? Is it, but there are, there's a group of CDC retirees that's organized and a number of other federal employees that are working together to try to understand, is it providing information to the media? Is it contacting government, contacting elected officials? Is it running for office? What are the things that you personally feel like you can be knowledgeable about or be effective at? And every invitation I get, I think, is this something that I would be good at, or does it make sense? But I do have some thought about not wanting to wipe out the credibility that I hope I built by being nonpartisan.
And I think you, as an advocate, you can be nonpartisan. You don't have to represent one side or the other. I mean, people, we're really worried about the safety of vaccines. Well, everybody's worried about the safety of vaccines, and we research that to remain a credible source of information to balance what we know about how well they work. And everybody should care about that. But there are ways that you can be nonpartisan and bring your story. You have a wealth of experience as a government worker, and things bring your story to other people. Then, as Anne is saying, how can you use that to have the most impact?
Thank you, that helps. And I'm actually scientist emerit. I'm still a special volunteer. So I have to still be kind of nonpartisan.
So Nick, why don't you ask the last question?
Happy to. So this is a question I feel like I would ask in a different audience. I can tell from the questions that this is a very learned audience. But for the average person, how do you think about how they should deal with or conceptualize public health threats in their own lives at this moment, when it feels like, who do we trust? Is the CDC there? Is the CDC paying attention, preventing these illnesses? How do you suggest that everyday people sort of build their life when CDC maybe isn't there at this moment?
Yeah, I mean, for everyday people, the CDC is pretty invisible, but I do think everyday people want their family to be healthy. And, my area for many years was infectious disease and vaccines, and I start with the idea that parents want their kids to be healthy, and they want to get the best they want to have somebody they trust so that they get the best information so that they can take the right steps. And so I think that is where, if you're used to, in the old days, you trusted your doctor, you trusted the nurse, you trusted the pharmacist, maybe you trusted your mother-in-law, you trusted certain people. And now you're maybe trusting something online that you may or may not know who those people are. I would say go back to the in-person. And I'm not really big on do your own research because, honestly, it's like a full-time job to do your own research. But the people who want to do their own research, we should make it easy for them to do that. But I do think that I really do feel like, Americans want their families to be healthy. And we need to make it easy for them to do that.
And the people who feel a mission to work at CDC are the same people that are likely to be brought into the agency in the future. I think it's an agency that pulls people who have a commitment to this kind of work. So whether they're able to work in the same way that they have before is yet to be seen. But I think you can trust that the people who are drawn to that kind of work will be doing their darndest to make sure people are safe.
Dr. Brooks, Dr. Schuchat, thank you so much for doing this.
Thank you all. Thank you all for coming.